of you have seen the specimen of molar pregnancy in our department museum. So how many of you have not seen molar pregnancy specimen? How many of you have not seen? Please raise your hands. Molar pregnancy specimen, how many of you have not seen? So everybody has seen. So all of you will not fail to identify the specimen, at least I think. If there is another specimen, so that will also be given. So number one. Number two, this molar pregnancy, medical importance is separate, but from examination point, it can come as a long question like bleeding in early months, which is going on, this is a revision class. That means either it is a abortion, or it is an ectopic, or it is a molar. So early months bleeding is basically out of these three. So previous two has been discussed. So this is the last one. And from medical aspect, the molar pregnancy is not a pregnancy. It is a high risk pregnancy, but without a fetus, because this is potentially malignant condition. Potentially malignant. So if the care is not taken about the malignancy, so patient may die of malignancy later on after the molar pregnancy is evacuated. So that is about the importance. So to start with, you know all this thing because a lot of classes, I think number of classes has been taken on molar pregnancy in your SGD class. This is an abnormal trophoblastic proliferation. Trophoblast is a proliferative tissue, we all know, but in this condition, this is proliferation is more and more, and this is a disease of the placenta because fetus is not there. So if the disease arises from the placenta, incidence is 1 in 400 in India, but in European countries the incidence is less. So in our country it is more, and more in Asian population. So benign disease with malignant potential, as we have stated. Next is, so macroscopy, this is one, but specimen in the department is the pregnancy within the uterus, that molar tissue within the uterus. So usually, what are the usual questions asked from the specimen? So diagnose, describe the specimens, that means it is a specimen of uterus, enlarged uterus with some mass, vesicular-like mass inside. Then you will be asked, is it a, what is your diagnosis? You say it is molar pregnancy. Then it will be asked, it is a benign condition or a malignant condition. Obviously you will say it. Then it is a complete molar or incomplete molar. Obviously there is no fetal parts, so it is a complete molar. Then you will be asked how the patient is presented, will be presented to you, how the patient, what is the problem with this condition. Then you have to tell the clinical picture of molar pregnancy, then we will discuss all these things. So these are the usual questions, and then it will be asked how will you manage. So that will be discussed in the following slides. So specimen of complete mole, specimen of complete mole on macroscopy. So what is the features? Vesicles of varying sizes, so arranged in clusters, areas of hemorrhages. So you see area of hemorrhage, this is due to separation of the molar tissue from the uterus. So areas of hemorrhage, then fetal elements, if it is found, some fetal elements, some limbs or some amniotic membrane, then it is a partial mole, and thicker luteal cysts on both the ovaries. So ovaries will be enlarged, but that is enlarged due to the hormone secreted by the trophoblast, that is beta-hCG, and high hCG release from trophoblast. So this is because that creates the thicker lutein cysts. So along with the molar pregnancy, you get the lutein cysts in the ovaries. So that is not a ovarian tumor, that is due to excessive stimulation. So after the molar pregnancy is treated, then evacuated, then cyst will be regressed, cyst will regress. So that is about the macroscopical picture. This is the picture you see. These are the vesicles, these are the areas of hemorrhages, this is a large vesicle, and these vesicles contains what? This contains edematous fluid. So vesicle is due to fluid accumulation in the interstitial tissue, trophoblastic proliferation, and the secretions of the cell accumulated in the interstitial space in the leading to vesicle formation. So that is the picture. Then you come to microscopy. So if you put it under the microscope, so basically without microscopy, macroscopically you diagnose it is a molar pregnancy, but microscopy is practically needed or specially needed where you are confused that it is a benign or malignant. So trophoblastic proliferation is there, so that will be in the macroscope is this. So these are the trophoblastic proliferation, and this is the edematous fluid within the space outside the villus, within the villus. Within the villus, the stroma is replaced by the edematous fluid. So that is the villus is edematous, and this is the proliferation of the tissue of the trophoblast. Then you come the edematous stroma and vesicle formation, vascular degeneration. So blood vessels are not there. You find there is no vessel, there is no blood vessel with the here. So there is vascular degeneration, absence of blood vessels. Villus structure is present. That is very important. If the villus structure is maintained, like this, then it is not a malignant condition. That is a benign condition. If the villus structure is broken, so no villus structure is found, then it is a malignant condition, that is called choriocarcinoma. So that is the difference. If you don't get any villus structure, that means that is a choriocarcinoma, and if you get the villus structure, that means that is a molar pregnancy, benign trophoblastic proliferation, molar pregnancy. And cellular atypia not found. In spite of so much of proliferation, no cellular atypia. So you know the features of cellular atypia, that is nuclear cytoplasmic alteration is not found. So that is about the microscopy. Then why does it happen? Why the placental tissue normally which is formed, the villus structure and the cotyledon is not formed, instead they are transformed into vesicle. The basis lies within the chromosomal abnormality. So fertilization chromosomal makeup is 46XX. 46XX is the chromosomal makeup, but these 46XX is not coming from half from the mother and half from the father, but all these 46 are coming from the sperm. So how did it occur? How does it occur? So 23X, it gets duplicated after fertilization. The maternal chromosomes remains inactive or lost, and the paternal chromosome is duplicated. So duplication of paternal chromosome leading and inactivation of maternal chromosome. So this is the abnormality at the chromosomal level and leading to 46XX. It is called, embryological term is androgenesis, and that is complete mole. If it is a complete mole, then the structure by karyotyping you can differentiate whether it is a complete mole or your partial mole, that is whether it is 46XX or not. So if it is 46XX, it is complete mole. Then you come to or in other way, molar pregnancy can occur, that is the formation of partial mole. So dispermy. So instead of one sperm, the ovum gets fertilized by 2 sperm. So then what will be the chromosomal number? 23X into 23X or 23XX or 23Y. So in that case, the number will be 69. So chromosomal number will be 69, maybe 69XX or XY. So fertilization by 2 sperm and maternal chromosome is active. So that is triploid and partial mole. So that is 69XXX or XXY. So if you get the karyotyping of the molar tissue like this, that will be partial mole. Why we are discussing it, the partial mole or complete mole, this partial mole, the malignant potential is very, very less than 5%. So usually follow-up is not necessary. But in case of complete mole, the malignant potentiality is about 20% or more. So follow-up is needed. So if we get to know, if we know that this is a 69XXX, so follow-up will not be needed. So both maternal and paternal chromosome is there, and both maternal and paternal chromosome is identified by P57 immunohistochemistry staining. Staining with P57 is positive. So this is a gene found in the maternal chromosome. So that if that is positive, that is negative. If it is not found, that means maternal gene is absent. If it is found, that means maternal gene is present. So it will be a partial mole or it will be a normal pregnancy. So amniotic sac and fetal parts are present. In partial mole, amniotic sac and fetal parts are present. So chances of malignancy less than 5%. That is the importance of diagnosing and chromosomal karyotyping of the fetus to know whether the molar tissue you are dealing with is a complete mole or partial mole. So here is the diagram, 23X, so gets fertilized and duplicated, 46XX, then the cell division goes on. And here is the disperm, means 2 sperm are entering a ovum, 23X, and gets 23XY, XXY or XXX. So it will be like this, XXX or XXY, triploid cells, both maternal and paternal chromosomes are there. So clinical picture. So this may be given as a long case of early pregnancy bleeding, and how will differentiate between the condition, how will diagnose the condition. So bleeding because of separation of molar tissue and amenorrhea obviously because of pregnancy, fertilization and amenorrhea followed by bleeding PV, and pain abdomen because of uterus is distended with the molar tissue. So uterus trying to expel the molar tissue. So on the pain abdomen means uterus is trying to expel the molar tissue, or really it may be, if it is invasive mole, the molar tissue is penetrating the uterus, giving rise to pain abdomen usually, or it may be distension of the uterus also. So pain abdomen, amenorrhea followed by bleeding PV and pain abdomen. So this is the combination triad found in all the early pregnancy cases. So exaggerated morning sickness because beta-hCG is very high, so that will give rise to morning sickness. Exaggerated morning sickness usually responds with the conservative management, usual management of antiemetic drug. But in this case, if you find that in a case of early pregnancy coming to you without these things, but having exaggerated morning sickness or not responding to your usual treatment, go for USG to detect whether the case you are dealing with is a molar pregnancy or not. So exaggerated morning sickness, early onset preeclampsia because of this high hCG level, the blood pressure may go high, and early onset means before 20 weeks. Usually we know the preeclampsia occurs after 24 weeks, definitely not before 20 weeks. So, but in case of molar pregnancy, it can happen as early as 20 weeks. So if you get the early onset of preeclampsia, think of the molar pregnancy, so go for ultrasonography. Sometimes with features of thyrotoxicosis. And hCG has the power like thyroid tropin like activity, so it stimulates the thyroid to go a high thyroxine level. So patient will be presented with the tachycardia, palpitation, and all those things of thyrotoxic, high temperature, so raised temperature. So all the features of thyrotoxicosis will be there. So thyroid tropin like effect of hCG. So clinical picture is all these things. So may come with bleeding, all these things, may come with preeclampsia, early onset, may come with exaggerated morning sickness. Any things can happen, or sometimes may come with thyrotoxicosis in pregnancy. They are all clinical pictures. Then come to the signs. So with all those symptoms, what signs you get? You see, because of bleeding, definitely you get pallor. Even external bleeding may be less, but it may be concealed bleeding, so pallor will be there. And BP may be high because of early onset preeclampsia, so BP may be high. And uterus in 50% cases, because excessive proliferation of the molar tissue is there, so bigger than period of amenorrhea. Suppose patient does come with, suppose is 10 weeks pregnancy, and you are getting the uterus palpable per abdomen about 14 weeks, that means it may be a molar pregnancy. So uterus is bigger than the period of amenorrhea in 50% cases, not always. Doughy feels means no, there is no fluid inside, no fetus, so doughy, that is some sorts of soft feel, that is no fetus, no liquor within the uterus, so that is doughy feel. And no fetal heart sound, fetal parts. Obviously, this question arises when the size of the uterus is like 20 weeks like that, and more than 12 weeks or 14 weeks size, where you are supposed to get the fetal heart sound, but it is not audible, or even in Doppler you will not get the fetal heart sound, and fetal parts of course later dates. So that is this is another sign that no fetus, so this is the molar pregnancy. Expulsion of vesicular mass, that is diagnosed. So patient is coming with bleeding PV with expulsion of some mass, and on examination you find that mass is vesicle-like. That means that is almost diagnostic of molar pregnancy. So even without ultrasonography, will be able to diagnose when the molar pregnancy is present to you with the expulsion of vesicular mass. So that can be a question the patient has come to with the expulsion of vesicular mass. How, what investigations will you do, and what treatment will you do? So that is the science. So investigations. So what investigations will you do? Obviously, the ultrasonography. So molar tissue secretes hCG, you know, but that is secreted by normal pregnancy also. So that is not much helpful. Though in molar pregnancy, the beta-hCG will be very high. If it is more than 1 lakh, then almost you can suspect that it is a molar pregnancy. USG reveals snowstorm appearance. So this is also a question given on the OSCE by showing you the picture. So this is the picture. This is the mass, no fetus, no lycoramniae, but cystic spaces. These are the fluid spill spaces, and this appearance is called honeycomb appearance, snowstorm appearance. Snowstorm appearance is the picture. So this is the diagnosis of molar pregnancy. So on snowstorm appearance the molar pregnancy, echogenic mass, but anechoic areas that I have shown, and no fetus, no amnion, that is also not visible in that USG. Excessive vascularity of uterus on Doppler. So that Doppler I have not shown you. So on Doppler, if you do suspect molar pregnancy, the uterus will be too much vascular, but mass is lacking of vascularity because the molar tissue is lacking any blood vessels, so the molar tissue will be avascular. So uterus is vascular, but mass is avascular. So that is the feature of molar pregnancy on Doppler USG. So partial mole, so if you detect the fetal parts on amniotic sac, then it will be diagnosis will be partial mole by USG. And if the molar tissue you find the penetrating the myometrium, so myometrium and molar tissue interface is visible on ultrasonography. If you see that molar tissue is penetrating the myometrium, then our diagnosis will be invasive mole. Invasive mole is not a benign condition, but villus structure is maintained. So in that case, you may say that villus structure is maintained, so it is not choriocarcinoma, but it is locally invasive. So local invasion is also a feature of malignancy. So invasive mole is put under the classification of malignant mole. Invasive mole, molar tissue penetrates the myometrium. So when it penetrating the myometrium, you cannot take the molar tissue out. So beta-hCG, high beta-hCG level will be persisted, and so of course that because the villus structure is maintained, of course that tissue will be sensitive to respond to methotrexate therapy. So invasive mole is locally invasive and malignant, but villus structure is maintained. So picture I have shown, and then you come to other investigations. Yes, beta-hCG, serum beta-hCG, not the urinary beta-hCG. Serum beta-hCG is very, very high before treatment. So, but after treatment it will fall. So after 48 hours of evacuation, usually we go for estimation of beta-hCG, and that will act as a base level guide on which we will decide whether the beta-hCG is rising or falling. So baseline beta-hCG is to be done, estimation is to be done after 48 hours of evacuation, not after 96 hours or like that, after 48 hours, within 72 hours of course, because in that case it will show less and less level. So serial estimation 1 to 2 weekly monitoring of, and serial estimation is to be done after that. So one is baseline beta-hCG, then 1 to 2 weekly. So the protocol, different institution follows the different protocol. Usually we go for 2 weekly estimation. So serial estimation 1 to 2 weekly monitoring of the disease. So that is for monitoring of the disease. If we find that it is going high or it is not falling, plateauing, that means molar tissue is persisting. That means either it may be invasive mole or the molar tissue has been metastasis somewhere. So that means a hyperplasia was there, and that will be called neoplasia. It was a benign situation, but when after evacuation of the mole, it is not falling, that means it becomes a neoplasia. In that case, the terminology will be gestational trophoblastic neoplasia. Why it is gestational trophoblastic? Because that trophoblastic neoplasia also arises in a non-pregnant condition. That means ovary, because these things are all arising from the fertilized ovum. So ovum is there in the ovary. From ovum, there is a totipotent cell, so that tumor may arise, and that is called, in absence of pregnancy, that is called non-gestational trophoblastic tumor. But this is, we are discussing a gestational trophoblastic tumor arising from pregnancy. So that is the another entity. So X-ray chest, so one is beta-hCG estimation, another is X-ray chest, must be done before evacuation, metastatic, for detection of metastatic deposit. This metastasis can occur following evacuation, because molar tissue may go to the circulation during your evacuation or during contraction of the uterus. So that's why the before evacuation the X-ray test is to be done to see whether metastatic deposit is there or not. So if it is there, so measures is to be taken to prevent some complication, lung complication in that case. And CT scan brain metastatic deposit if chest metastasis. So brain metastasis is to be diagnosed by CT scan, so that usually we do if chest metastasis is there. Without chest metastasis, brain metastasis doesn't occur. So first is X-ray chest, and if necessary, they need CT scan to detect the brain metastasis. So if there is metastasis, that means that no longer remains a benign situation, it becomes a malignant condition. Treatment is, so treatment, if you are asked, this is the terminology you have to use: suction evacuation and follow-up, not dilatation, not on DC or like that. Suction evacuation and follow-up. That is whatever may be the size of the uterus. Even if it is, say, about 28 weeks size, still the treatment is suction evacuation followed by follow-up by beta-hCG, maybe USG, maybe chest X-ray, maybe CT scan. So suction evacuation and follow-up. So what precaution will we to take during suction evacuation? Because the risk is lot of bleeding. We do not know how much of concealed bleeding is there. Of course, USG may guide. And following evacuation, following separation, lot of bleeding, because uterus is very much vascular, as I have also stated. So lot of bleeding will occur if the uterus fails to contract effectively, and if the evacuation is not done very quickly, so lot of bleeding can occur. So blood transfusion is a must. So in APH, blood transfusion is a must. Blood should be arranged. So in case of evacuation of mole, otherwise patient will sink, go into shock during your evacuation, and will face patient will face the all complications out of shock. So blood for transfusion to be arranged, and blood grouping and X-ray chest. So blood grouping, why it is done, and X-ray chest also for metastasis before suction evacuation, and blood grouping whether anti-D immunoglobulin is to be given or not. Knowing completely that molar tissue does not contain any blood vessels, but still you are going for the blood grouping, whether the mother is Rh negative or not, because you do not know blood vessels are not there in the complete mole. Before evacuation, you do not know, karyotyping is not done, so you do not know whether you are dealing with a complete mole or partial mole. So if it is a complete mole, no anti-D is required, but it is a partial mole, anti-D will be needed. So that's why out of this controversy, in all cases, if it is Rh negative, the anti-D immunoglobulin is to be given. So anti-D immunoglobulin, that is a question whether you give or not, that is resolved by partial or complete mole. So laminaria tent for dilatation of cervix. So molar tissue, if on the way of on the process of expulsion, that is cervix is dilated, then you can easily go for suction evacuation. But if the cervix is not dilated, then you have to take measures to dilate the cervix or to make it dilatable by either by laminaria tent. So that is a seaweed which absorbs water and gets dilated, thereby it dilate the cervix, or by misoprostol. Misoprostol 400 microgram if you give vaginally, that will create ripening of the cervix and dilatation of the cervix. So, but that is laminaria tent for dilatation of cervix or misoprostol you can give, and oxytocin infusion during evacuation. While you are evacuating, you start the oxytocin infusion, which helps to contract the uterus, so it will facilitate the expulsion, number one. Number two, it will cause the less blood loss, so reduces blood loss. And that is helpful. Suppose somebody is not there and molar tissue is in the ward and call book came to you that patient is bleeding profusely. What will you do immediately? Before arranging the suction evacuation, you know the suction evacuation treatment, but before arranging, you start oxytocin drip. That will cause less blood loss, reduces blood loss, but risk is embolization. The molar tissue will go to the circulation because of the contraction of the uterus. So embolization of the molar tissue in the chest can occur, and that could create lung complication. But that is a still oxytocin infusion. Usually we give during evacuation, especially, and the immunoglobulin already given, already stated. Then it is surveillance, post-evacuation surveillance, that means suction evacuation and surveillance. Serum beta-hCG estimation, 1 to 2 weekly, as I have stated. So how to know whether it is falling or not? Fall must be by more than 10%. If it is less than 10%, then it is plateauing, not falling. So, and it will be normal by 6 months. If it is comes to normal, normals means less than 5 international unit per ml. Less than 5, so then it is a normal. So in that case, you know that no further surveillance is needed, and X-ray test for metastasis. No further treatment is needed, surveillance is needed, of course. X-ray test for metastasis is to be done. USG, that you can not like weekly like that, you can go by 3 months or at least monthly you can do. But if the beta-hCG level is falling, then you need not go for the detection of metastasis. So if it does not fall, then only you can go, because if metastasis is there in the chest, it will show, it will fail to show the falling. So X-ray test metastasis, ultrasonography to detect remnants of molar tissue and thecal uterine cyst. So if there is remnant, suppose you have not done evacuation completely. So evacuation is done, but some molar tissues remain inside. So what will happen? The beta-hCG will show that it will show that it is not falling. So in that case, it will also occur, and in that case, of course, you know that second your curettage. Second curettage is a treatment to take the rest of the molar tissue out, and it will be better because the uterus becomes thick. Because at the first evacuation, if you go for a curettage and all those things, curettage of course you have to do. Because of the softness of uterus, you can easily perforate the uterus. So if you do it after 1 week, the chance of perforation is less. And thecal uterine cyst, if it persists, that means beta-hCG level is high. So also this lutein cyst will regress. So either chest metastasis is there, or thecal uterine cyst is persisting, or the beta-hCG is not falling. That means it is not normal, so it is something abnormal. And that is called, yes. So plateauing of hCG level, day 1, then 7, then 14, then 21 also. So 1, 2, 3, 4. By 4 weeks, subsequently you see two levels are not less than 10% fall, that means it is plateauing. Less than 10% is plateauing. Or instead of fall, it is rising more than 10% on 2 occasions, 1, 7, 14 and 21. That means also it is rising. So fall and rise, that in that way you define, not normal after 6 months. So even after 6 months, it comes to normal level. That means it is not normal, and in that case, in all these situations, the diagnosis or molar pregnancy is changed to gestational trophoblastic neoplasia. It was hyperplasia of the tissue, but now it becomes neoplasia. That means it has the malignant potential. So change of diagnosis. So during follow-up, if the beta-hCG fails to show fails to come to normal, at least this criteria, so then the diagnosis is gestational trophoblastic neoplasia, and that is the indication for chemotherapy. So chemotherapy we do not start back because molar pregnancy has occurred, because chemotherapy is very toxic. So chemotherapy we do in these situations. So that is the change of diagnosis. If you do not give chemotherapy in these situations, it will cause further growth of the tissue and cause metastasis in brain. So that will be a very grave situation. So gestational trophoblastic change of diagnosis. So what about the prognosis following molar pregnancy? So question is whether you are allowed the conception at later months or not in the woman. So conception allowed 6 months after normalization of beta-hCG level. 6 months after normalization of beta-hCG level. After normalization, not after the diagnosis. Oral pill may also be prescribed after normalization as a measure to prevent conception during these 6 months. If there is conception during 6 months, in that case pregnancy is a possibility. So in that case you have to do USG to detect whether the woman has conceived or not. Risk of recurrence of molar pregnancy is 1% like that, less than 1% risk of recurrence, and risk of choriocarcinoma is 10-20%. So, but outcome of pregnancy, if the pregnancy occurs, the pregnancy outcome is normal. There is no question of teratogenicity. So pregnancy, there is no question of other complications of pregnancy because it has occurred following molar pregnancy. Prognostic risk scoring in GTN. What are the situations where risk of gestational trophoblastic neoplasia is high? Age is more than 40. You know why in the specimen in the department the molar pregnancy suction evacuation is the treatment, but that is what is the operation done in that case, that specimen? It is hysterectomy. Why hysterectomy is done? Possibly because age was nearing 40 like that. So more is the age, chance of GTN is more, and that is the situation. So hCG level more than 1 lakh. If on baseline hCG is more than 1 lakh, that means chance of gestational trophoblastic neoplasia is high. Antecedent pregnancy, whether it is following molar or normal. If it is following molar, it is less, but it is following normal, the chance of GTN is more. So interval from pregnancy more than 4 months. So molar pregnancy, the GTN can also occur not only following your molar pregnancy, but this can also occur following normal pregnancy, following abortion. So in all cases the GTN can occur. So interval from pregnancy more than 4 months. So following normal delivery, after not within 1 month or 2 months, but after 4 months, if there is beta-hCG high, so diagnosis is gestational trophoblastic neoplasia, that gives a poor prognosis. And metastatic site and number. So if it is metastasis in the brain or in the liver or spleen, so how many metastasis is there? So depending on that, it becomes a gestational trophoblastic neoplasia. Chance is high. Thecal uterine cyst more than 6 cm. So usual thecal uterine cyst may be there, but if it is more than 6 cm, then the chance of gestational trophoblastic neoplasia is high. So in this way, you will find a chart in the book where the score, if it is 1, 2 or 3 like that, if the score is more than 7, so there is high risk of GTN following molar pregnancy. So what chemotherapy is given? Single agent is methotrexate injection, day 1, 3, 5, 7, and 2, 4, 6, 8, the leucovorin injection will be given. That is folinic acid. So leucovorin is folinic acid. So methotrexate and folinic acid. So that prevents the bone marrow suppression, folinic acid. or injectio etoposide, more toxic. So either of these two can be given, but this is more toxic. Score is less than 7. So on this table, depending on this table, the score is less than 7, then all the single agent. If score is less than 7, single agent chemotherapy. If score is more than 7, it is IMACO. IMACO means etoposide, methotrexate, actinomycin D, cyclophosphamide and oncovin. So multiple agent, this will be more toxic, but it could be given depending on, otherwise it will not respond. So that is about chemotherapy. And is there any place of surgery, as it has happened to that case in our department? So age is more than 40, surgery you can do, but as you have removed the uterus with the molar tissue, that does not mean you do not go for follow-up. So follow-up is necessary. So even with hysterectomy, follow-up is necessary. And other conditions where hysterectomy necessary is bleeding, following evacuation, bleeding is not controlled. So in that case, even with bleeding is not controlled, so emergency you can give, or if it is diagnosed case of following molar pregnancy, usually responds to methotrexate also, but usually if it's still not emergency situations, you can go for hysterectomy following evacuation and removal of theca lutein cyst. So place of surgery is not there. Because there is theca lutein cyst, you need not require in surgery. You have to control by the chemotherapy, the beta-hCG activity you have to control by chemotherapy. No place of surgery for the theca lutein cyst. So that is about surgery. And so differential diagnosis, as you are telling, very important. So from the USG, what could be the differential diagnosis? That picture may be out of missed abortion. Because you know missed abortion, placenta is there, fetus is not there, only gestational sac is there. So that is give rise to like this. But so much of, if the cystic spaces are less, so the picture will be same. Hydropic degeneration, this is not due to hyperplasia trophoblastic tissue. This tissue is idiomatous because of degeneration. So degenerated hydropic changes in the placenta may occur. That is not a hyperplastic situation, that is not a molar pregnancy, that is hydropic degeneration. So and degenerated fibroid and with pregnancy testimony. I can remember a case where the patient of coming with recurrent bleeding PV, and possibly the amenorrhea period was missed and pregnancy was not diagnosed. About 16 to 18 weeks size uterus, it was diagnosed as a case of fibroid and treatment was going on. Then with the testing of serum beta-hCG, it becomes high. So degenerated fibroid was being treated, a molar pregnancy was being treated as a case of degenerated fibroid. So the diagnosis changed and treatments also changed. So pregnancy test is negative. So if you think that it is a degenerated fibroid, go for pregnancy test which will be negative. And serum beta-hCG is low in all these situations, hydropic degeneration, missed abortion, all these situations beta-hCG may be detected, but that will be low. And immunostaining, if you cannot distinguish, so you go for immunostaining. If it is positive, that means it is all these pregnancy situations, not the molar. So in case of complete mole, it will be negative. So if it is positive, that means these are the hydropic degeneration or missed abortion or like that, and you can go for karyotyping also. So follow-up in all these situations not required. Follow-up is required in all these situations. So that is about the differential diagnosis. So classification by this time, what we have stated in the beginning. So benign is highly deformed mole and partial mole. Malignant is invasive mole. It is locally malignant and villus structure is maintained. then the choriocarcinoma, placental trophoblastic tumor, endothelial trophoblastic tumor. So placental site trophoblastic tumor, this very name suggesting that it occurs at the placental site. So especially following normal pregnancy it can occur. Beta-hCG is a little bit high, but bleeding is not responding to any sorts of treatment. So presented with placental trophoblastic tumor, if you go for beta-hCG, it will be high. And endothelial trophoblastic tumor, these are all rare, but choriocarcinoma is not that rare. So it can happen, and we have seen the patient to be admitted in our department with respiratory distress. Just on the beta-hCG estimation, it was found that very high. So that was a metastatic chest disease which was treated by so many chest specialists, but on gynecology it was detected to a case of choriocarcinoma. Of course, she came so late, we had not been able, it was not been possible to save that patient. So summary is a benign disease with 20% chance of malignancy. Diagnosis and monitoring done by beta-hCG level. So hCG level is diagnosis not so important, especially for monitoring, and chemotherapy cures the disease. So this is the chemotherapy not only in molar pregnancy but in choriocarcinoma also. So this is the disease, that means choriocarcinoma or gestational trophoblastic neoplasia is diagnosed not on the basis of histopathology but on the basis of hCG level, that means tumor marker. So tumor marker, on the basis of tumor marker, this is the disease which is treated and diagnosed not on by histopathology. So we do not go for whether the villus structure is there, we do not go for the histopathology specimen to see, so on the basis of beta-hCG level. So pregnancy allowed after 6 months of normalization of hCG. So that is about, and prognosis I have already stated. So that is about the summary. And invasive mole that already discussed. So peritoneum, so trophoblast grows, respond to chemotherapy. That is very important. We do not have to resort to hysterectomy. So presented as gestational trophoblastic neoplasia. So whenever you find the GT level is not falling, it is a GTN, a likely invasive mole, and by Doppler you will be able to diagnose. And placental site trophoblastic tumor it will be presented as a PPH, so not sensitive to, and the problem is beta-hCG is low, and problem is here the proliferation of the cytotrophoblast is there. It arises from the intermediate trophoblast. So not the sincere trophoblast. That's why it is not responding to chemotherapy. Not responding to chemotherapy. So in this situation, if it is placental site trophoblastic tumor, this is will be presented as gestational trophoblastic neoplasia. That means it's a malignant. So hysterectomy will be needed. So that is the rare situation. So one of the conditions where PPH is not responding with all those things. So beta-hCG is to be done even after say 3 weeks or 4 weeks. If the beta-hCG remains high, you have to think of placental site trophoblastic tumor. Thank you. Thank you for your hearing. ঠিক আছে, some of you possibly are going to the ward for giving a long case item. So one after another. So next batch will also be long. The item will be cleared one after another. So today is long case. So next day, if you come and you suggest another, the OSP will be taken, then instrument, the specimen. So one by one, the batches you are attending the OPD clinical classes. In that group of students, we will take the items.